Thank you, Ahmed. Thank you, BI. Thank you, Angels Initiative, and the audience listening to me. Uh, I'm such an honored to present this important topic on stroke mimics and chameleons in this educational platform. My name is Dr. Waqar Gaba. We'll move on to my disclosure. The outline of my talk today we'll first talk about stroke and definition of TIA, one slider. We'll then move on to stroke mimics. What are they and what are stroke chameleons? How frequent these stroke mimics are and do they really get thrombolized? We'll then move on to the real cases and I'll give you some clues to diagnose those stroke mimics. And in the end, we will differentiate in one slide those stroke mimics between each other and differentiate it from the stroke. So how do we define stroke and TIA? Two words in red: rapidly developing clinical signs of focal disturbance of cerebral function. They have to be focal, they are sudden, okay? Lasting 24 hours or more. That's how it can be differentiated from TIA. Now, TIA, as you now know, they are brief episodes which are typically lasting less than 1 hour without any evidence of acute infarct on brain imaging. So they can last up to 24 hours, but mostly they are brief episodes again focal, brain or retinal ischemia, and lasting less than 1 hour. It's very important to recognize stroke from the stroke mimics. I follow this principle, which is the duck principle. So if it looks like a duck, swims like a duck, and quacks like a duck, then probably it is a duck. So what's very important is that not only the definition, but I'll give you my practical definition of stroke, which essentially means that should be look out for focal neurological dysfunction. The onset, like as I said, should be in seconds, not minutes or hours. Look out for negative phenomena. I know you should know about this positive and negative, okay? The negative phenomena is like loss of power, loss of sensations, loss of vision, but not loss of consciousness. So loss of consciousness goes against this, though beware of, again, brainstem strokes. Look out for vascular risk factors. So essentially, what we are saying, it should be quick, it should be focal, it should have negative phenomena, no loss of consciousness, and look out for vascular risk factors. So what we're saying, it's an acute neurological event that could be a stroke or TIA, but it can be a stroke mimic. So what is stroke mimic? Which looks like a stroke, but actually it's not. So you can see it sounds like it, but it's not, okay? What are chameleons then? This is a picture I took myself from Dubai Aquarium. And as you think that there's nothing there, but if you spot it, you can see a stroke there. This is chameleon. So looks like other conditions, but actually they are stroke. We will more focus on stroke mimics than chameleons in our topic today. These are the stroke mimics you will see or observe in any A&E. You will see seizures, you will see syncope, you will see sepsis, functional patients, primary headache disorders like migraine, brain tumors, and so forth. The percentage might be a bit different, but these are the more common ones you will see in your A&E. This is a nice paper from Clinical Medicine RCP, from Hasu, London, from Antipatera, Jeffrey Cloud colleagues. 2,000 patients, as you can see, they were in Hasu in London. You can see that 1 in 4 had stroke mimics. So these are the patients who got admitted in hyperacute stroke unit with a possible diagnosis of stroke, and 1 in 4 had mimic diagnosis. 2/3 actually had at least one stroke risk factor. So You can't blame yourself. These patients were being admitted in there, and still you can see high percentage. The most common diagnoses were headache, seizures, and syncope. So does it really matter? It does, because you are admitting a stroke mimic in an HASU, in hyperacute stroke unit. You are wasting the bed, you're wasting the resources. They might get the wrong workup. So essentially they might have something else, and they might get MRI, Holter, CT angiogram, MR angiogram, echo, all those things, which they might not need it. Okay? So it's a waste of resources and wrong workup. And also, more importantly, if they come in hyperacute settings, you might harm them. How you can harm them? You can thrombolize them. So, do you think the stroke members get thrombolized? Of course they do. So this is from the SITS registry. As you can see, 400 patients out of 10,000 patients. That's 4.1% of the stroke mimics getting thrombolized. So then it's get with the guidelines. This is equivalent version of US, which again you can see 2,000 patients out of 72,000 patients. So 3.5% again got thrombolized. And this famous George's actually quite recent article showed us in 2015 that 5-year meta-analysis he did and find out from 8,000 patients, 392 got thrombolized. So again, there 3 to 5% patients can get thrombolized. But once they get thrombolized, do they get the bleed? Surprisingly and reassuringly, they don't get the bleed. Well, they do. In sets, you can see 2 symptomatic intracellular hemorrhage out of 429, so 0.5%. In Get With the Guidelines, 11 out of 2,500 patients, so 0.4% again. And in meta-analysis, 2 again. So essentially, we're talking about 0.4 to 0.5% of the stroke mimics who got thrombolized get the bleed. In a nutshell, in a rough pool estimate, we're talking about 1 in 6,000 IVT treatments getting. So the mimics who then getting thrombolized, 1 in 6,000 is the number who will get the bleed. Where it appears the most safe is actually functional disorders, demyelinating disease, peripheral neuropathy, and peripheral vestibulopathy. So if you thrombolize these patients, so far, thankfully, there has been no reported published reports of hemorrhage after thrombolysis in these patients. So let's move on to our cases. Okay, so case 1. These are all, by the way, real cases I came across during my stroke experience in either as a fellowship in London or during my consultant being in UK. So first case, 45 years old lady. Some risk factors you can see: ischemic heart disease, hypertension, diabetes, osteoarthritis. So you have some risk factors, vascular risk factors, found lying on the floor by her husband. So it is sudden, okay? Generally weak, confused, and slurred speech noted. LAS call, that's London Ambulance Service, were called. They found her to have dysarthria, word finding difficulty, and globally weak in all 4 limbs. I hope you would have picked up by now that yes, it's sudden. Yes, it looks like a stroke because there are some vascular risk factors, but it's globally weak, generally weak. So this is not focal. This is a real case. I was called as a registrar to see this patient, okay? And all I asked for one test. One test, if you would ask for, is sugar. So sugar, not surprisingly, it was 2.1. That doesn't mean that every patient you will check sugar will come as 2.1. Also remember, strokes can have hypo and hyperglycemia. So they might have a dual, you might have a dual pathology as well. So watch out for those as well. But in this case, this was just a hyperglycemia. Let's move on to next case. So another case, I was referred, 60 years old gentleman who was referred, came with the family with sudden onset of global aphasia, which lasted 5 minutes. So referred as a possible TIA. When I found that there was no limb weakness, he was confused and tired afterwards as per the family. And he couldn't recall actually what happened. When I took the history, I find out that he did have an hemorrhagic stroke 6 months ago, from which he recovered quite well. had a bit of residual weakness, quite recovered well. So this is sudden, but no limb weakness, amnesia. This sounds like a seizure. Now remember, you can have again as a primary epilepsy, but this patient had a hemorrhagic stroke. So this sounds like a more of a stroke-related late onset seizure, but also you have to think about stroke as well. In this case, more clues towards the seizure. You must have heard of Todd's paralysis. Famous Robert Todd, Irish physician from London, had described this Todd's paralysis. And what he describes is that they normally progress over seconds to 1 minute. So the progression there, it is quite quick, but it takes a bit of time. You should have positive symptoms. Now, positive symptoms like jerking and tingling are not present in stroke patients. They last minutes, but can last for hours or days even. It usually causes a hemiparesis, can cause aphasia, sensory loss, and very rarely hemianopia. Now, the stroke seizures actually are more common in cortical ischemic or hemorrhagic strokes, so watch out for them. They're generally stereotypical attacks. So these are enough to differentiate seizure from the stroke. Let's move on to our next case. So this is a 25 years old lady, probably easier case, was a medical student, came in with progressive sensory symptoms. She could explain they were progressive. Right arm. She then felt after 5 minutes having a speech problem. She had 10 minutes later had some right arm felt heavy. So there's like a gradual progression of the symptoms over a few minutes. And she also described some headaches since morning, gradual onset unilateral headache. When I took a bit of more history, you know, in the family, there was some history of migraines as well. This is migraine until proven otherwise. So just to know that, you know, that 1 in 4 women can have migraine at least once or twice in their life. 50% of the neurologists, there was one study showed, can get migraines. Actually, more than 80% in this paper showed the female headache neurologists get migraine. So it is quite common. Actually, myself, I get migraines as well. So what are the clues for hemiplegic migraine? Like we said, it's gradual onset. We talked about positive and negative symptoms. So now we know stroke, negative. We talked about seizure, positive. In hemiplegic migraine, you can have positive and negative symptoms. Stereotype. Stereotype is not a nature of a stroke. Progressed over 3 to 15 minutes. They're typically young. They can have 4 subtypes: familial hemiplegic migraine and sporadic. And usually familial with first-degree relatives with attacks. So take a very detailed history that do they have themselves or in the family first-degree relatives with headaches. Next case. So next case is a 40 years old lady who actually, very interestingly, had a sudden onset chest pain. So initially paramedics thought that this patient could have an MI. And then followed by left-sided whole body pain and weakness. She came via air ambulance. She was crying and quite emotional throughout the journey, we were told by the paramedics, and actually in the hospital as well. When the ED examined them, they reported 0/5 power in the left arm and the left leg. So obviously they asked for thrombolysis. Well, this patient turns out to be functional. Now, I'm going to give you some clues towards functional, how we describe these functions. Sometimes it can be tricky. One thing, remember, pain at onset. Pain is not a feature of a stroke. Hoover sign, which we'll talk in a second. You might come across some patients who are just mute. So they will be doing everything. You'll ask them to raise their arm, do the leg test, follow the commands, everything, all perfect. But they're mute. And even sometimes they do the gestures of they are trying to say words. Okay, this mute Global aphasia without hemiparesis is very rare in stroke. You might ask them to walk and they might have a give way feeling. There will be fluctuating neurology. Same as famous call like beware of label indifference, labile indifference. Labile indifference means that essentially you will be telling them they had a stroke and no emotions or very inappropriate response. It's actually not the same thing as malingering. It's more of a conversion disorder. What I used to describe it as a software, not a hardware problem. So be smart and do examine them as a smart physician. How can you be smart? You ask, when you see them that they have zero power, ask them to get out of the bed or help them to get out of the bed. You will be surprised they have zero power in the trolley, but they could still sit up and they could walk with a bit of problem. They might have a give way feeling when they walk. Look for sensory and visual inattention. If they do have it, they might fluctuate the signs because they wouldn't know exactly what you mean, and they would fluctuate with one side or the other side. The next thing is Hoover sign. If Hoover's is positive, you have a very strong suspicion of functional failure. So how you do the Hoover test? It's easy. Keep it simple. Ask them to lie flat. Okay, lie on your supine position. Just ask them to raise, let's say there is right-sided weakness. Ask them to raise their right leg. So they would say it's a zero power. Okay, so they cannot raise. Okay, ask them to extend the hip while you put your palm below their right heel. Okay, and again, you would expect because of the zero power, they're not able to extend the hip. Now you put your left arm now, you have your right here. Now you put your left arm on the hip and ask them to flex the hip against the resistance. When they do it, the natural response is when you flex the contralateral hip, there should be extension of the hip. If they are normal, you will feel the pressure. If you don't feel the pressure, either they are really smart or they have a genuine weakness. Last case. So this is another very important topic you can say you come across on a daily basis. I get so many phone calls about these patients who have, this was a 40 years old lady who had a sudden onset rotatory vertigo and vomiting. And sometimes they just vomit and vomit and vomit. Okay, and they come with a lot of vertigo, nystagmus as well. This lady had conjugate horizontal rotatory nystagmus beating to the right. So, of course, it can be anything. It can be stroke, no vascular risk factors, but obviously in this case, we thought that she had acute vestibular syndrome or peripheral vertigo. Now, let's talk about acute vestibular syndrome. Remember to ask them about new onset tinnitus or hearing loss, because if this is present, this is peripheral. This is a clue. Although you can have an acute hearing loss with ICA infarct, acute inferior cerebellar infarct, although it's quite rare. You should have no other neurological symptoms like no weakness, no other symptoms except these acute vestibular syndrome. Watch out for 4Ds and 2Hs. So 4Ds are diplopia, dysphagia, dysphonia, and dysarthria. Also, keep an eye on 2Hs, which is Horner's or hiccups. So if you get any of these, you are talking about central rather than peripheral. So to recap, you should not, if you have a new tinnitus hearing loss, this goes towards the peripheral. If you have 4Ds or 2Hs, goes more towards central. All the patients with ongoing vertigo, when you see them and having spontaneous nystagmus, do the Hinds test, which we'll talk about in a second. And those who having short episodes, like less than 30 seconds episodes of vertigo, initiated mostly by the head movements, we usually call them as BPPV, benign paroxysmal positional vertigo. They normally have no spontaneous nystagmus. you can do Helpic maneuver. But remember, don't do hints and Helpic maneuver on the same patient. So let's move on to hints. What is hints? Hints stands for head impulse, nystagmus, and test of skew. It's 3 tests. What we already established, you should be doing on somebody who is having ongoing vertigo and spontaneous nystagmus. Okay. You start with head impulse test, you then do direction changing nystagmus, you then do test skew deviation. By the way, if you do them properly and you have a good practice, if any of them are positive, it's highly sensitive and highly specific for peripheral vertigo, peripheral acute vestibular syndrome. It's actually better than acute DWMRI, because if you do it acute DWMRI, it might be 80 to 90% positive, but in this case, it would be 100%. So how you do head impulse test? Head impulse test actually tests your vestibular ocular reflex. So essentially, you are checking if it's positive. Remember, this is reassuring. So that means it is peripheral. So you hold on to the head. You can actually do virtually as well. Ask the patient to look at me on the camera and hold your head. Although with this one, head impulse test might not have good response, but you can do that, like hold on to the head and fix your head onto the camera or one point. You then just move it nicely so that the muscles are relaxed, and do like this, and quickly, briskly move them to the center. When you move them, keep an eye on their eyes, okay? You might have to remove their glasses if they're wearing. So do this. And when you do this, you should look for catch-up saccade. If this is present, this is peripheral vertigo until otherwise. That's head impulse test. Let's talk about nystagmus. So nystagmus, as you know, first just look at the primary gaze. Can you see any nystagmus? Then, and if it is unidirectional, ask them, again, you can do virtually. It's actually quite a good test to do virtually. Ask them to look at me on the camera and move your eyes without moving your head. Move your eyes on the right and move your eyes on the left, okay? And see if there's any nystagmus and if it's in one direction. And then specifically ask them to look at the finger and again, move them on the right and move them on the left, okay? And see the direction, whether there is any changing or not. If it's in one direction, this is again peripheral. So this is reassuring if it's unidirectional. How about test of skew? Now that can be tricky, but I'll again tell you how easy it is. It's simple, cover and uncover. So even can be done virtually. So they're looking at the camera, ask them with their own hand, they cover their one eye and then the other eye quickly. When they cover and uncover, you are specifically focusing at the uncovered eye. So from here to here. So you are looking at the uncovered eye and look for vertical skew deviation, which is reassuring if it's not. So there is no vertical skew deviation. That means it's perfect. So this diagram will tell you, differentiate between what central hints means. So on the top, we just established head impulse is normal. So essentially, you this, and what you feel is that there is no saccade of movements. Actually, this is normal. So spontaneous nystagmus must be present in these patients before you do it, like we established before. Head impulse is negative. This is central. You then look at the nystagmus, and if it's vertical or bidirectional, both directional or multi-directional, this is again central. Then you check the test of skew, cover, uncover, and specifically look for the upward movements, the vertical movements of the eye. If they are present, this is central hints. I hope I have explained them nicely to you. Let's now focus on this slide, which differentiates between those mimics which we discussed, and focus on one by one rather than looking at the slide altogether. because it might be tricky. So let's focus on stroke on TIA. So essentially, we talked about seconds onset, negative phenomena. We talked about no loss of consciousness except vertebral and risk factors. If it's a seizure, you can have progression over seconds to 1 minute. So although it sounds like quick, but be specific that how long it took to develop. Okay, there are positive phenomena. There should be loss of consciousness. It is possible loss of consciousness. And look for whether they had epilepsy or some brain lesion or stroke in the past. What about migraine? Migraine, again, not that quick. So this was seconds. This was seconds to a minute. And this is over 3 to 15 minutes. So although they sound like, oh, I get the headache very quickly, but ask them, was it quickly, like how long it took to develop those headache? Or these symptoms, or these focal negative or positive symptoms like weakness or numbness. There will be no loss of consciousness, and there might be history of past migraines. This case we didn't discuss. You will come across a lot of them, but it's sometimes easier to pick. So this is a patient who looks sick, who has a fluctuating onset, will have confusion on the background of some cognitive impairment, like an old nanny, and she'll have some abnormal blood results, maybe septic. Actually did have a very good case who was presented to me as a stroke, who actually turned out to be meningitis. And there was a very, very stiff neck. Okay, comes with a weakness. Vertigo, acute peripheral vertigo. We discussed this. It might not be hyperacute. They might have new tinnitus or hearing loss. They might have no other neurological symptoms or signs. And there will be nystagmus, but not vertical, not multidirectional. And you would like to do Hinds test or Halpeak's test in them. Functional, like we said, it can be variable onset. They might tell you it was sudden in onset, okay? But then the history will change. The neurological signs will change. Or maybe there might not be objective neurological signs. So they're mostly like a sensory impairment where they can say loss of sense, okay, on one side. They might have some possible previous psychological issues. So again, you need to work for stress. Be nice to them, be kind to them. Tell them it's a software problem, not a hardware problem. You will not use the word of this, but essentially tell them it's not them who are doing it. It's actually their brain is making them do it. So remember your S's. You might think they can't be all S. Actually, I can prove you. All stroke mimics, or most stroke mimics, they start with S, like a seizure, like a sugar, which is hyperglycemia we talked about. Sepsis, we just talked about. SOL is a space occupying lesion. So you might have an ongoing problems, but now presented with some weakness. Spasm, like a migraine. Somatization, functional patients we talked about. Syncope, they passed out. Substance misuse. So as you know, more young generation using a lot of things. They sometimes come with a stroke caused by the substance misuse, but or maybe the symptoms are just related to the substance misuse. So there might be always double pathology as well. Remember that. Subdural. You do the CT and you find out they have subdural. And don't forget, sometimes there's just a social reason. They have, you can even either group them as functional, but if they're not actually functional, they have genuine problems, social reasons for coming to the hospital. So one of the last slides, there is something called telestroke mimic score, where you have age points, AF, hypertension, like we talked about, vascular risk factors. Actually, if the score is more than 30, it's likely stroke. If it's less than 15, it's likely stroke mimic. This might be more and more used in ED settings. I personally am not a big fan of it. More rely on the clinical skills. And there's also a FAB score in the ED, when if it's more than 3, you can watch out for that. It's likely stroke mimic. So last slide, take home messages. History, history, history. It's always in the history. You get the history of how the onset was, where the weakness was, how long it took to get these symptoms, what were the associated symptoms, what were the risk factors. This is will give you a clue. Think of the age and gender. So as we know, younger patients have different pathologies. We now know also that there's some tendency towards females having migraines or functional patients more. Although I'm not gender biased, but this is a reality. 1 in 5 strokes referred as hyperacute will be mimics. So don't worry if you are diagnosing somebody as a stroke, which later turn out to be stroke mimic. But do your best. Watch out for stroke chameleons. Like as I said, there are some hidden strokes which you might label them something else. Actually, they are stroke. Of course, and imaging helps, but your clinical acumen prevails. Thank you. Thank you for listening to me. I'll be happy to take questions and hope you learned